Hi, everybody. I want to welcome you to Pediatric Grand Rounds. Today is one of our Frontiers in Child Health Research seminars, and I'm very pleased to introduce our speaker, Dr. Janet Wojcicki, who's a professor of pediatrics and epidemiology here at UCSF. She has an interest in early life risk factors for the development of obesity, and she is also interested in maternal exposures in pregnancy and early life feeding decisions that can increase risk of obesity by age, and also has international experience, particularly in sub-Saharan Africa, in evaluating the relationship between nutritional factors and HIV. Today, she'll discuss how prognostic models can be used to prevent childhood obesity by collecting data in the first 6 months of life. So please join me in welcoming Dr. Wojcicki.
Thank you so much, Dr. Hirsch. I was just letting people know that I've actually been at UCSF now. Actually, July will be 25 years, 22 years in the Department of Pediatrics. And this is my first Grand Rounds lecture. So very excited about that. I feel a bit that it's a bonus point to, actually having been duration of 25 years. So anyway, thank you so much. So today I'm going to be going through, it's a bit of a career history as well, like how actually I got to this project. And it kind of weaves in a bit my background and, different decisions I made, people that influenced me, and kind of where I am going forward as well. But I will be speaking about prognostic modeling for childhood obesity by 5 years of age, and the role of leukocyte telomere length in particular as a marker, kind of as a secondary interest. Okay, so everybody is kind of probably worn out by seeing all these graphs and figures of the problem of pediatric obesity in the United States. And I sure am. But I wanted to just put one up because it seems important to kind of situate us where we are. But young children are not excluded from the issue of obesity in the United States, even children as young as 2. And, I was initially trained actually as an anthropologist. I came to public health and medicine a bit later on in my career, but was quite interested in what I guess drew me was the prevention, the ability to actually prevent. I did quite a lot of work in Southern Africa at the time of prior to the access to antiretroviral treatments when HIV was a massive issue. So became quite interested in prevention as a way to kind of lessen, of course, human suffering and poor outcomes. And with obesity, I kind of transitioned when I came to UCSF in 2000. I initially came to the Department of Medicine, did a HIV fellowship for a few years, and then Mel Hyman recruited me to the Department of Pediatrics in 2003 for a nutrition fellowship. And he encouraged me, actually, I had been doing work on HIV, and he encouraged me actually to look at the issue of obesity in children. And what was very compelling for me at the time is it seemed like there was quite a big need for prevention. And I'll go into kind of why I believe that. But from this graph here, you can see, right, of course, that young children 2 to 5 years of age have shown a marked increase in obesity in the United States. There's been some leveling off, as we got into 2020 with preschool obesity, but still, a marked increase from what we saw in the 1970s. And, you know, what I saw kind of as an anthropologist, anthropologists are trained in observational techniques. Like the bread and butter of anthropology is actually writing ethnographies and actually doing a lot of observational note taking and evaluation. And my experience really was that there was kind of this one size fits all prevention to childhood obesity. So in other words, right, you go see your primary care provider, your pediatrician, and there are kind of bullet points that are mentioned in terms of what a new mom, dad should do to prevent childhood obesity. And it's breastfeeding, it's responsive feeding, it's good sleep hygiene, it's, you know, reduction in screen time, it's good timing of introduction of solids. So, you know, there's kind of this one size fits all. Let's tell everybody the same thing and then hope that, you know, these lessons will be learned and that we will, you know, prevent childhood obesity in our population. And these tend to be, a lot of the recommendations tend to be family-based, right? For young kids, you got to actually get the whole family involved. And so, you know, this is just, I put up here, you know, kind of the complexity that can be involved in terms of preventing childhood obesity, right? So it's like the goals can be to actually change the structure of a lot of family dynamics. So eating meals together, you know, limiting fast food, removing even TVs from, you know, certain areas of the home. So many of the prevention approaches for obesity tend to be family-based. And again, here's just another schematic, which basically shows, right, you actually, not just the family, but community as well, right? So it's not just what the child does or the parent does, but actually like community in terms of, you know, access to recreation, accessibility of good foods, school lunch programs, you know, for children that are in preschool programs, you know, access to healthy foods in the preschool environment, neighborhood safety. So it's a complex problem in terms of actually preventing and intervening. And actually, here's a clinical practice guidelines for actually treatment and evaluation by AAP for children with obesity. So kind of moving to prevention, you know, why we really want to prevent is that there's a lot of effort that needs to go in once a child is already obese, right? I mean, I put this up here because it really models obesity as a chronic disease, the need for treatment intensity and a variety of different approaches, including shared decision-making with patients and families, cultural competent care, you know, focus on, you know, stigma, structural factors, health inequities, racism, adverse child experiences. So very complex chronic disease. And, you know, this was interesting to me also because the way that it was actually, if you can see right here at the bottom of the arrow, it's kind of describing obesity as a remitting and relapsing type of disease, which isn't always how we think of obesity, but as we, you know, might think of something like substance use disorder, for example. So as I mentioned, right, I came to UCSF in 2000 and actually transitioned to investigating obesity in 2003. And at the time, just kind of doing a PubMed literature review. And even now, you can see a lot of the focus is kind of on these single risk factors for obesity. So a lot of people, or a lot of publications like breastfeeding, to what extent might that impact or modulate risk for obesity, maternal exposures, you know, is the diet in pregnancy, prenatal BMI, you know, stress, environmental exposures, but the majority of the studies really focus on these kind of single risk factors. And what I realized is Well, actually, it wasn't me. I had a fellow, Jake Robson, in 2016, who's now actually a pediatric GI at Utah, who was like, God, I'm just tired of seeing all these like individual studies. Like there has to be something different, something that's more powerful and better than that. And actually looked at adult medicine and realized, wow, we have so many risk scores and algorithms in adult medicine to help the clinician predict future onset of disease, like the Framingham risk score, for example. It's been around for quite a long time. And prevent American Heart Association, also cardiovascular disease, heart failure. And yet we didn't really have anything that I could find for pediatric obesity. So I just put up here just the Framingham risk score, for example. It's quite simple. You add a number of different variables that give you your 10-year risk for cardiovascular disease. Age, HDL, some basic, metabolic parameters that an adult would have potentially, or a clinician would have at his or her fingertips to actually assess, like, what is the risk for that patient. And this actually is a much more comprehensive prevent, also for cardiovascular disease, but includes other factors, including kind of beyond what Framingham does, also looks at, socioeconomic factors, include zip code, tobacco use, other medication use. So a little bit built up from Framingham. So, in adult medicine, we kind of have this model. There's a lot of risk scores that clinicians can actually use to be able to kind of then, triage in some way. Because what I saw, like as an anthropologist, as an observational person, was, wow, there's like, this is a huge issue in terms of prevention. Is there not some way to kind of triage these patients and figure out really who is at the greatest risk? And so, I mentioned Jake Robson was a fellow at the time and was interested in childhood obesity and working with my data. And I basically had 2 birth cohorts that I recruited, mothers in pregnancy at ZSFG and actually here at UCSF as well. One in 2006-7 and the other in 2011-2, 11-12. Both were primarily Latino birth cohorts, just based on the demographics that we have here in San Francisco and particularly at ZSFG. And I had looked, I had done a lot of, I had enrolled these women when they were pregnant, I'd collected parameters at the birth. I'd followed these kids for many years, looking at pediatric obesity outcomes. And I had been looking, at a lot of these kind of single risk factors for childhood obesity. So I looked at breastfeeding, antibiotic use, childcare practices, maternal depression, other exposures in pregnancy. And then really it was Jake Robson who was like, let's actually do something where we let's combine some of these risk factors and see what are the most predictive and what kind of algorithm could we potentially use for childhood obesity at age 5. Age 5 is a good time point because it's before kids enter primary school, right? So, and the goal really was to not actually burden the provider. So to focus on variables that were part of the medical record, because there's no point in having a risk score if the clinician is going to have to do a lot more, right? Then it's more like it won't be done. It's not going to be helpful. So the goal really was to kind of try to have something that would facilitate the ability to predict and then streamline triage care. So we worked with one of my cohorts that we had. That was the sample size was 201, and I just put up some demographics here. Jake looked at a bunch of different variables, in terms of like whether the kids were obese at age 5 or whether they were not obese. And maternal predictors, we looked at a variety of different things in terms of demographics. The only one that was significant was maternal pre-pregnancy BMI. Oh, sorry, just to go back, just of note that we had 26% of this cohort was obese at age 5. And then we looked also at infant predictors. So, some of these were, like I said, not necessarily in the medical record, but perhaps had been suggested as possible risk factors by other researchers. So, we looked at timing of introduction of solids. We looked at, whether vaginal delivery, C-section, infant sex, and then the factors in the first 6 months of life. And so the ones here that were actually significant, we found weight Z-score, birth weight Z-score, and then the Z-score change from birth to 6 months of age, as well as gestational age. And so Jake developed, we had 2 models, kind of large model with 10 predictors, and then a reduced model with only 5. And so the 5 included the weight for age Z-score change from birth to 6 months, the birth weight Z-score, maternal pre-pregnancy BMI, maternal age, and whether the baby was exclusively breastfed or not at 4 to 6 weeks of age. Those were the 5 that we had in the reduced model. I have the other ones up here as well, but what became less interesting because we found that the reduced model worked equally as well as the full model. So I just put up the algorithm here, just, the actual calculation. We have a paper in 2016 that has this information as well. And, doing a ROC curve, the area under the curve was 0.82. So actually the model worked pretty well in terms of sensitivity and specificity, with 0.8, a relatively respectable guideline in terms of what is clinically meaningful. So as I said, the full model and the reduced model, like there wasn't too much difference between them. And, 5 variables is not a huge thing in terms of having a clinician, to build an algorithm and have a clinician be able to input those variables. And we actually, what was reassuring is we did a random forest classifier plot that actually mirrored quite well what we saw in our multivariable analysis. So in other words, the 5 variables that were significant to us were also significant when we use different statistical techniques to actually, evaluate what was predictive, again, of obesity at age 5. And I just put up here the sensitivity and the specificity. So the model basically, when we looked at different risk thresholds in our population for obesity, like just arbitrary risk thresholds, we found actually that the specificity of the model was pretty good, like at the higher thresholds, 84% and 97%, but the sensitivity was pretty low. So in other words, we were missing some of the positives, but we could be pretty confident with our negatives. Okay, shortcoming of the model, of this model, was a small size, right? We developed it based on my birth cohort of 200 mother-child pairs. We were restricted here to San Francisco, Latino population. And when you do these types of algorithm development, usually you want to have a training model and then a validation. And because we had only 200, we actually had to use statistical techniques. We actually had to bootstrap which was, actually get these kind of generated samples to test the validity of the model. So there were some shortcomings that we had. And so what I decided to do, sorry, there's a fair amount of kind of, tables and kind of statistical calculations for the next few slides. But what I decided to do was actually test the model in diverse cohorts from around the country. And so what I did is I reached out to other investigators who had longitudinal childhood obesity cohorts, including Chamacos, which is actually a rural base. I don't know, some people may know Brenda Eskenazi over at Berkeley, who has it's also a Latino cohort, but it's rural in the Central Valley here in California. I worked with Project Viva, which is a large Harvard-based multi-ethnic cohort in the Boston area. SIPS, which was or is a multi-ethnic cohort in New York City. And then I had another cohort that was less restrictive than my initial cohort at ZSFG. So I just put up the demographics here. You can see that 3 of these mainly 2, mainly Project Viva and SIPS were, the most important thing for me really was to have a multi-ethnic cohort, because our cohort really was restricted to San Francisco and only Latino infants. So really wanted to try to have a broader test of our model in these other groups. And I just put at the bottom, you can see the obesity rates in these other cohorts. So the cohort that the model was developed from, we were around 20%, 25% obesity at age 5. These other ones were between 11%, which was Project Viva, and 32% Chamacos here in the Central Valley for obesity. And we actually, if you look at the numbers here, we had, similar values in terms of the function of the model. So kind of close to 0.8 for area under the curve for all 4 of them. And we actually tried to add race and ethnicity to the models for those that actually were multi-ethnic, and not finding that actually added at all to the predictive value. So these were pretty close. SIPS was actually 0.829 and the others were 0.7 or so. And then we also did the same random forest classifiers, finding actually that for all of these variables, there was some shakeup of what was significant, but this weight Z-score change from birth to 6 months of age was among the top 3 variables for all the cohorts. And there's Project Viva and Chamacos. And we found a similar high specificity, but low sensitivity. So the same issue that we had in our initial development was similar here. In other words, we were missing, we were missing some of the positives, particularly at the high thresholds. Okay, so then I pivoted a bit. This was, right before COVID in 2018. I thought about, okay, I'm interested actually in, I've done a lot of work here in San Francisco, Latino children who are high risk for obesity, but what about an environment where we actually have lower obesity risk? And I had an option at the time through Council on Foreign Relations, Hitachi, to spend 6 months in Japan at University of Tokyo and Chiba in 2018, 2019. In retrospect, I think how lucky that was because it was right before COVID. But part of my interest in my work there was, again, working with these birth cohorts from diverse areas, and trying to see, right, actually, what are the predictors for childhood obesity at age 5 in a very, very different setting. And so I just circled here. I ended up, this project is actually still ongoing. And I ended up partnering with 5 different cohorts. So one in the north in Hokkaido, at the Hokkaido University, which is the island where I've circled Sapporo, Tohoku, which is in the north, the second circle there, 2 kind of in the Tokyo Chiba prefecture, and then 1 down here, Hamamatsu. So actually 5 cohorts from different areas of Japan. And I just put up here, interesting, because you can see that, I mean, the Japanese are very concerned about obesity, of course, right? Because of what's happening, globally, what's happening in China with obesity and other neighboring countries. But they really, their numbers do not reflect whatsoever like what's happening here in the United States and other industrialized countries. So the top one, I believe, is the prevalence of thinness, normal weight, and overweight and obesity. So in Japan, you really kind of have to combine overweight and obesity because the numbers are small for obesity alone. And you can see that, the red is the one at the bottom, is Japan at the bottom. And you can see it's pretty flat for overweight and obesity over from 2010 to 2023. And this is the data from the 5 cohorts that we can look at, or that we looked at. And you can see, let me draw your attention to the rows at the bottom. So you can see in these cohorts, the prevalence of obesity was very, very low. We put 1 of these cohorts, 4 of them we looked at age 5, and 1 we could only look at age 3. So that's why it says age 3 to 5. But you can see that it's between 1.7 and 4% obesity. So very different from what we see in the United States. And then the overweight, higher, but still only really between 6% and 11%, 12%. So we actually did the same algorithm. We used the same algorithms, same variables that we used here in the United States to kind of see, like, is this going to work in a low obesity setting? Finding that the, let's see, I'm doing for time. Finding that the model actually didn't do terribly, right? It wasn't as good. It wasn't above the 0.8 threshold, but it was in the high 7s. This was for overweight, though. We had to model. We could not model for obesity. So we actually had to change a little bit our model based on the Japanese situation. We had 2 cohorts that were much bigger, that were in the size of 2,000, 3,000 participants, Chiba and Hokkaido. And for those 2, we actually could look at obesity. And those, it was comparable, 0.8 actually for Hokkaido and 0.75 for Chiba. And I just put the numbers up here quickly, but we did the exact same, used the exact same variables. We used CDC growth curves for the outcomes for Japanese children. We actually tested, Japanese actually have their own growth curves as well. And we tested a couple of the cohorts using those, using obesity modeling, using Japanese outcomes, and finding that the obesity was actually slightly higher. So it moved from like 3% to 6%, but the model functioned in a comparable way. And I just put up here very quickly, we have the same problem that we saw in the US cohorts, that we had a low sensitivity, particularly at the higher thresholds, but a good specificity. And this is Hokkaido, same thing. And then obesity versus overweight. Also, good negative predictive value. So in other words, our negatives could be pretty confident in them, but we were missing some of the positives. Okay, so now I'm going to pivot a little bit. Hopefully I have enough time to actually go over this, but because my research, I developed this model, like I said, in 2016, and then I had these different iterations, like testing it out in multi-ethnic cohorts, and then we tested it out in Japan as well. But we had this problem of sensitivity, right? So like, are we going to be able to pick up all the kids that potentially could be positive very early on with a metric that's collected very early in life, right? It's not necessarily a tragedy, right? If we have somebody who is marked positive, but they're not really positive, because the interventions for obesity are pretty benign, right? In terms of family counseling, really intensive, or more concern potentially from the provider. At these ages, there's not going to be like a medical, there's no pharmacology that's involved. But again, I was still like looking to be great to have some type of model that is highly sensitive in terms of picking up everybody that could be positive for obesity early on. And I had been doing prior work on telomeres and related to obesity. And so was actually quite interested to investigate the possible role of telomere length as a variable to be able to predict disease outcomes. Okay, so for those of you that are not familiar, telomeres are the non-coding segments of the DNA that are particularly sensitive, that protect actually the caps at the ends of the DNA that prevent or protect DNA from damage and degradation, particularly from reactive oxygen species damage, inflammation, chronic disease, and prevent cellular senescence. So shorter telomeres are associated with chronic disease in general because of the exposure to inflammation. But there's kind of this circular feedback loop. So in other words, telomeres get shortened just by the process of aging. As we age and every cell divides, we actually telomeres get shorter with every cell division. So it's a natural, if you look at population-based studies, infants have the longest telomeres, and then they get progressively shorter as we age. But there's this kind of feedback loop that can happen as well. In other words, that shorter telomeres can actually be involved in the production of pro-inflammatory cytokines. So in addition to being sensitive to reactive oxygen species damage, they actually can facilitate that process. And actually put up here, there's been a lot of work that's been done on this campus, in particular looking at the role of stress and psychological health and telomere shortening. And actually that's how I kind of got involved in this study, or in this type of work in the first place. So I put this up as well, right? Because kind of bringing back to like, why telomere for this question of prognostic models and algorithms, is that a child's telomeres at birth can be a good marker of a number of different exposures and factors. So if we're looking at something that can kind of hold a number of different, give us an idea of a number of different insults, or environmental as well as genetic factors, telomere I thought could be an interesting or potential good predictive variable. And I just put up here, if we think about like at birth, a baby's telomere lengths, there's going to be both impact from paternal effects, maternal effects, as well as just overall genetic. So for mom, right, mom's BMI, there's a number of studies, mom's health in pregnancy, her preconception health, and dad's age, dad's health, as well as just genetics. There's telomere length to some extent is genetically determined. And what we had been doing, our group had been doing for a long time, is as part of the newborn genetic screen. I mean, everybody here knows, right, that babies, there's a heel stick, 24 hours of life. It's an opt-out procedure, California newborn screen. Babies get tested for a variety of different genetic diseases in the first 24 hours of life. So quite easy for us is we were able to add on our telomere assay at this same time point in the first 24 hours of life. So I thought to myself, this is something that potentially could be something that could be collected quite easily. And I've been doing this work for a while, not necessarily related to prognostic modeling, but we've collected, this is a separate study, not the actual heel stick, but we also collected cord blood at some point in time and found that actually maternal socioeconomic status was quite well associated with telomere length. So moms, moms, we didn't necessarily find anything in this particular study with stress, but if you think of social deprivation as a type of stress, for sure, then that actually resulted in kind of accelerated shortening for the baby at birth. And then we had another study I just put up here as well, longitudinal. We do know that chronic obesity, at least in adults, can result in accelerated shortening over time. This was actually an adult study that we did with the moms from the same cohorts. Also pediatric studies, been quite interested in. We did a lot of, again, not necessarily the prognostic modeling, but we looked at other exposure. So example, we also looked at sugar sweetened beverage consumption at 2 years of age, finding that kids that actually had greater consumption of these beverages had shorter telomere length. This cross-sectional, not necessarily predictive, but we were finding some evidence of behaviors that were obesogenic and shorter telomeres. And there's quite good predictive data from the adult literature on the role of telomere length to predict metabolic disease. So this actually meta-analysis looking at telomere length and risk of type 2 diabetes in adults. 3 prospective large studies finding that quite predictive of diabetes onset. And then this also cardiovascular disease, again, in the adult studies. So the role of telomere as a potential predictive marker seems to be quite good. So this was encouraging for me in terms of thinking again about our prognostic models. And we have some data. I have a third longitudinal cohort study that we actually decided we called telomeres at birth study that we finished enrolling. It's about 600 babies. And we should be they should be close to 5 years of age, the cohort as a whole in 2027. But we've looked at some preliminary outcomes in this group, and did find that if we looked at obesity at 12 months in this cohort, again, looking at telomere length collected at birth as part of that heel stick, that it did add value in terms of it was predictive of obesity, not at 5, but at 12 months of age. So as I've mentioned, we do have a new cohort, 600 babies. Hopefully we can split it into a testing and validation cohort, more multiracial, multi-ethnic, and follow up until 2027, 5 years of age. And ideally, we're interested, a lot of the work that we've done has been kind of abstract, just in terms of, right, like, is this model predictive or not, but really eager to work in the clinical setting, right, to actually see, how might this function in terms of being able to tell mothers and fathers in the first year of life, like, your child has, a 90% risk of obesity at age 5, for example, and how that actually may, how parents would feel about that, how clinicians would feel about that, how that actually might work practically in the clinical setting. And just as in terms of Japan, I'm still working with that group. We have yet to publish our findings from those 5 cohorts, but it did appear that the model actually did work, not as well. And the false negatives may be less important, as we know that interventions for obesity are timely, consuming, and costly. And that's it. Thank you to everybody, in particular the Peds GI. That's, I've been a division member for 20 years. A number of different organizational groups funded this work, including NIH, NASPGHAN, Hellman Fellows Fund, Marcus Foundation, Hitachi Council on Foreign Relations for the work in Japan. And then, of course, all the fellows, Jake Robson, who kind of helped me initially with, came up with some of these ideas, and all the students who've worked with my data over, the past 15, 20 years. And then lastly, of course, the Blackburn Lab, Alyssa Epple, for the insight on telomere length, and my research would never have gone. Sometimes where you are determines kind of what you end up doing. And 100%, if I hadn't been at UCSF, I would not have gotten interested in the possibility of telomeres as a biomarker for disease outcomes. So thank you very much. I'm excited to get any questions from the audience.
First of all, thank you. It's great to see all your work together like this. Collected any blood samples at 6 months? Like, I'm thinking about how you might apply this, and you mentioned, kind of going into the model, you were like, let's look back at the data we already have, right? But and then you're going to apply it at 6 months, but you might not have those telomeres. And I mean, you will in your cohort, obviously, but I'm like thinking about applying it in the clinic. Are there other things like that could improve the sensitivity at that time?
Yeah, I mean, I'm 100% open to suggestion. And the wonderful thing about a cohort is you can actually add, right, as you're ongoing, or, I mean, retrospective data is not as good, for obvious bias reasons, but to, if there's thoughts, I mean, we went back actually and with the antibiotics, right, asked patients about antibiotic exposure, childcare was another one, right? As as different publications have come out over the years, we've actually looked in our cohorts to see, is that predictive in our particular data set. So, there's nothing, I mean, I'm open to anything, right? Like,
I was also thinking about the thing, chronic inflammation that affects. I don't know. I mean, we tie all those things together.
Right. I mean, I guess for me, an important thing was definitely not to burden the clinic.
Yeah.
Right. To actually, if something is going to be sustainable, right, we're just looking also at the adult risk scores, right? It has to be something that's already in the medical record, or something that's easy that they could say, like, mom, like, what's your age, right? Or something like that. So, another blood, particularly like an esoteric blood assay, right? Or an invasive test, I was like, no way. But, a lot of the things that we've tried haven't necessarily added value, to the model. I mean, a big one really is that weight for age Z-score change, right? Which we know, like, from lots of studies, like, I kind of, dismissed a lot of the single variable predictors, but that's one that is actually quite significant across the board in terms of predicting, obesity outcomes.
A little bit to that, but said that you are 600 implications, potentially telling a parent their newborn has obese at age 5. And so I guess, given how challenging it is in terms of work you've done and others to prevent obesity, I feel like, then if you know that you also have these shortened telomeres, I'm sort of starting to get it, like, what are the chances of that being able to be effective in terms of some of those interventions?
Yeah, I mean, I think that's a great question. What I do think is that it's better use of the clinician's time to actually counsel that family versus this kind of like everybody is kind of getting the same stuff, So I think if it's marked then in the record, right, then, that is something that, particularly if we think of obesity as this kind of like relapsing, remitting chronic disease, with the longitudinal focus, then really that is it's more use of the valuable time in the clinic, right? Or with the dietitian or whatever, whoever the referral is made to. So I do think, yeah, there are those challenges. And then downstream, we have like the GLP-1s and the bariatric surgery, all that. But like, right, even before that, ideally, if it was my kid, right, I would rather do something in the first couple of years.
A couple of questions from the Zoom audience. One person says, thank you for your talk, and asks, can the model also predict NASLD risk?
Yeah, I wonder who's asking that.
It's Ala Abdelghani.
Oh, okay. Yes, we've done work in that. I was wondering if it was someone from GI. Yeah. So I've also done work with MASLD and telomere length, less actually in this cohort, but more from the the larger MASLD-based studies in the United States, and we haven't directly looked at that, but that would be my hope, is to actually be able to use it as a predictor for MASLD. We have a subset of my cohorts. Actually, Sarah Maxwell has been working quite closely with me looking at predictors for MASLD in my population. So a subset of our cohort, we actually tested. We got LFTs and other markers that could be predicted of MASLD and looked at predictors of that. But it was a smaller sample size, so we didn't include telomeres in that cohort. But it's something actually we potentially could do. So thank you for that question. Yeah.
And then the other question is probably more common. That it's so interesting that your postdoc knew about things like the brain study that are being done in adult medicine and adult medicine. Collaborate.
Yeah, 100%. I mean, it also just speaks to like the wonderful, the wonderful experience that we can have in an academic center like UCSF in terms of the trainee exposures. That it's just right. Any PI, 100%. It's a bi-directional relationship. So.
Thank you.
Thank you.
Thanks for coming.